Hello everyone. Today I'm going to talk about my topic, converting free text to FHIR, unlocking EMR data value with AI and standards. So a quick introduction of who I am, and I think Anil covered most of it. I am a director of solution engineering at Verto Health, as well as a lecturer of software engineering at the University of Toronto. This is my third time presenting at FHIR North. I did two presentations all about Verto's FHIR capabilities, and this is actually a planned one of the third presentation of my series of three that I've planned 2 years ago. So really excited to be talking about how Verto is using NLP to convert into FHIR. So before we get started, just to prime the background, why NLP? Like, why is NLP so important in the healthcare space? And it goes without saying that 80% of medical data is actually stored in unstructured format. And so legally required, clinicians do embed extensive details within free text clinical notes, putting things like their upcoming immunizations, their conditions, what they're testing for, what's the differential diagnosis. All of that, these extensive details are only available in free text clinical notes. And there are efforts, obviously, as well for clinics to tell their doctors, please just document it properly in the right place in the EMR, but they often don't double document. In fact, with one of the clinics that we worked with, only 4% of clinicians chooses to double document the information in their relevant structured fields in their EMR. And the reason why they don't do that is because they want to spend most of their time providing patient care and not becoming data entry clerks. And so hours are wasted on manual chart reviews, right? And manual chart reviewers are hired just to complete the documentation in structured formats. These are the five most common things that we see chart reviewers doing: due or completed immunizations, screenings, the relevant lab results. Again, these lab results, most of them are do exist in the clinical notes. When a clinician needs to make a judgment call based on a lab report, they are required to put the results in the clinical note for documentation purposes and for audit purposes. And we also see a lot of documentation that is missing in structured data, important for reporting, that is, again, available in the free text note, not available in a structured format. Allergies is another huge one and almost does not exist at all as part of structured in structured format. One of the missed opportunities here is actually a program by Ontario's Ministry of Health on claiming the cumulative preventative care bonus. And one of the biggest barriers to this is because the requirements of this preventative care bonus, all the data, that's stored in unstructured text only. That is why NLP is so important nowadays to ensure that we have a full holistic view of the patient population. But that goes to the point that NLP, clinical NLP itself, existed for decades. This is a problem that a lot of people have looked into, and there are so many commercial clinical NLP products out there. And so the second question that I have is, why is Verto NLPing to FHIR? Why is FHIR the way to go? The first reason is that clinical data is more than just it is and it is not. You think about there are a lot of clinical research done to on the negation space, whether or not the patient had a COVID vaccine or whether or not a patient did not take a COVID vaccine. There are very popular NLP clinical NLP libraries that deal with negation. But what we did realize is it's more than that. And so here are three examples. Either so the first one is patient has the clinician has ordered colonoscopy to rule out colorectal cancer. Colorectal cancer is not something that the patient has, or it's is it's something. It's actually it's right now something that they don't have, but it's a layer on top of that. It is a differential, unconfirmed diagnosis. The clinician is trying to rule out whether or not this patient has colorectal cancer. Similarly, here's another interesting example of question mark T2DM. This is more of a primary care dialect. The question mark in front of T2DM denotes that it is a suspected diagnosis. Further information is needed to confirm whether or not the patient has type 2 diabetes mellitus. And third of all, here's an example of 2x TIA in past 5 years. So the patient indeed had the condition of a mini stroke, a TIA, but it's not a current problem. It was a historical problem. It's not, the patient is no longer experiencing the condition, but it is still worthy of being kept track of being in the patient profile as a past history of illness. And FHIR very nicely is designed to store this information. In terms of condition, there's a condition.clinical status and condition.verification status, and they're well-defined statuses. They have a standard definition that everyone understands, and here I screenshotted kind of the what FHIR provides as the definition of active, inactive, unconfirmed, confirmed, and even refuted. And to compare this with other healthcare analytical models, it's worthy to note that popular data models like OMOP, which is actually very popular and commonly used for healthcare analytics, does not contain such detail. So we did look into alternatives of FHIR, and OMOP was one of the top candidates. And we do see that in OMOP, there's also a table that keeps track of NLP data. And all they provide is whether or not the term exists, so whether or not the patient actually has or had the condition, and term temporal, which is present or past. That's the level of detail that analytical models provide, whereas in FHIR, there are more dimensions to it. The second reason why we should NLP to FHIR is solely because of the depth that FHIR objects provide. Here's another node example. Glyburide, 5 milligrams, 2 times daily starting June 24th, 2020. And so glyburide here is very important as something to keep track of in the patient profile. And a lot of NLP, clinical NLP libraries are able to correctly identify glyburide. But on top of medication names, supplementary information such as strength, dosage, and frequency is also very important. And in fact, FHIR has standardized the expressions of such information. They have a standard definition for strength, standard definitions for what should be kept track of in dosage, and also frequency. Again, clearly labeled, and on the right side, there's an example picture. You can also take a look at the official FHIR website for more of this information. Very documented, very easy to tell what the patient, how many times the patient needs to take it, in what cadence, what is the current dosage. So you can do a lot of analytical use cases like, well, is the dosage going up or down? Is the patient continuously taking less of the same medication? Is the strength decreasing, et cetera, et cetera? The reason number 3 is harmonization with structured data. And so this is kind of the most obvious reason why NLPing to FHIR is most important, because our other counterpart, 20% of structured data, is already in FHIR. We have been making huge progress in Canada versus in a lot of places. We've recently participated in the Projectathon earlier this year, and it's all about making data within systems interoperable via FHIR. Everyone is working on allowing their API, allowing their systems to be consumable via FHIR. In Canada, we have CAFEX, the Canadian Fire Exchange Protocol, which governs that exactly. And so when we extract concepts from free text notes, they should be consumable in the same way as structured data. Otherwise, when we are to answer the question, which patients completed colorectal cancer screening in the past 2 years, in the structured data, we're looking at FHIR, so we are looking at CPT codes, we're looking at LOINC codes, and in the conventional approach of NLP, in unstructured data, we're not querying by these codes anymore. We're looking at more free text. Yeah, albeit they are in like entity formats, but different ways of querying supposedly the same data to the end users would be less than ideal. The fourth reason is that FHIR works very well with many coding systems. And so Verto chooses UMLS as kind of our prime terminology set in order to code clinical concepts. And that is because UMLS offers a crosswalk to a lot of popular code systems that are jurisdiction specific. We have clients that need ICD-10 as the output. We have clients that require us to use SNOMED. We have clients that require us to use local jurisdictional specific formats, their own formats. And with this UMLS crosswalk, we could support all formats. Granted that we have a translation table from UMLS to the target system. And in FHIR, it's supported via codable concepts. So on the left side, you could see how a codable concept for type 2 diabetes mellitus is structured. You will have a code in UMLS C00111860. And with that code, we can easily translate that into its corresponding ICD-10 code. For example, for diabetes mellitus, it can get translated to E11. Now, there are many challenges in converting NLP and doing NLP and outputting in FHIR because a lot of commercial NLP solutions, well, some commercial NLP solutions actually do support this process. Here's an example of Azure Text Analytics for Healthcare, and they've recently built a product that allows conversion to FHIR structure. So I did test this out, and I gave an example sentence of colorectal cancer screening is due. A very common sentence that you will see in primary care notes. And so if you take a look at what we expect, the correct answer is that colorectal cancer screening as a procedure is incomplete. It's not yet completed. What Azure gives us is something that is incorrect. Instead of recognizing that colorectal cancer screening is a concept that we should be recognizing, Azure NLP falsely creates a FHIR condition object of colorectal cancer. And if you look at the FHIR object, you'll realize that Azure Text Analytics says that the colorectal cancer is a confirmed diagnosis. Furthermore, Azure Text Analytics also generically recognize screening as a procedure. Again, attaching it with an examination name. So it's actually, we can convert it into a procedure. That is wholly incorrect. The second challenge is commercial NLP has very poor entity linking to concepts. Here's another very commonly seen primary care example where we list out the primary problems that the patient has. And here I have a bullet point of T2DM, the most popular abbreviation of type 2 diabetes mellitus in the primary care space, and also HFrEF, heart failure with reduced ejection fraction. They come with ICD code of E11 and I50.2, respectively. The commercial NLP really disappoints us. In T2DM, it's not able to it's able to recognize that it is a diagnosis, it's a condition, but it shows as a condition without an associated code. So in terms of actionability, it's not an actionable thing that we can do with downstream applications. Even worse is HFrEF. Again, a very, very common diagnosis that a patient will get, especially in primary care notes, and in which it incorrectly identifies it as an examination name, again, without a code. So these are two of the prime examples where current commercial NLP algorithms really does not do well on converting to FHIR. Now comes the solution. Our solution is created in 3 steps. First, NLP models are trained natively on FHIR. Second, entity linking is trained on multiple vocabularies. In fact, over 10 million unique vocabularies are ingested, covering many primary care and acute care dialects that are absent in the UMLS Metathesaurus. And most importantly, under all of that, and is what we really aim to do, is ensuring trust of the data. We are applying AI algorithms. We are doing machine learning. And it is impossible to guarantee that we will output things that are 100% correct, as with all machine learning algorithms. And so the full traceability between source free text data and its respective derived concepts through the FHIR provenance model, we find to be most important. To show you how our solution differs, here's our statistics on benchmarking mock clinical notes made by our clinical advisors and labeled manually. So these are clinical notes that you will see in primary care EMRs. And you can see that in all domains, in medication, conditions, and procedure, we beat commercial solutions. We beat Azure by around 50%, and ChatGPT in this space does not perform well. Let's first talk about ChatGPT. ChatGPT is an all-purpose model, and with our tests, it's not even able to output FHIR compliant outputs. And if it was able to output FHIR compliant outputs, it did not have the right definitions in the fields. Again, taking note that in FHIR, each field has a standard meaning. Going back into my previous slide, each field, such as dosage, such as frequency, has a specific meaning, and you have to put specific things in there. In here, ChatGPT was not able to do anything at all. Now, you now might wonder, wow, Azure text analytics, like how can Verto, a small startup, beat a commercial NLP solution? Most people think that we've cherry-picked the result, but I have a great explanation on why Azure did not perform well in our real-world benchmarking. First of all, Azure is a generic NLP model. It was not built and it was not trained originally for healthcare. And so what it does, it needs to build a layer on top of the NLP to actually interpret the raw NLP outputs into the respective FHIR fields. With this translation step, there's 2 steps that can go wrong. The first step is obviously the NLP. Everyone some will struggle on it. It's something that everyone's worked 20 years on it. We will get some incorrect results. But there is a second layer that adds to the problem, which is not only does the output needs to be verified, it also needs to be put in the right FHIR fields. So this is the first reason why Azure does not perform well. Second of all, Azure is overfitted with Mimic 4 training data. This is our hypothesis. But in one test where we use a very popular free text repository of discharge summaries, we realized that Azure constantly outperforms Verto. And I gotta be kind of like transparent about that because we did not do as well as Azure in synthetic Mimic 4 notes. Not synthetic, but anonymized Mimic 4 notes. We performed around 70 to 80%. Azure performed 90% to 100% correct. They, however, fail entirely when we give it primary care data, which shows us that Azure's system is trained on publicly available notes in public domain, and they've labeled everything. So if you do a benchmark on things that are publicly available, they've already significantly labeled them already, hand labeled them, and trained that using their system. And third, the the UMLS is also used by Azure. It's not something that we have created. But as you can see, UMLS comes with its own constraints. T2DM, HFREF, that is actually two terminologies not within UMS Metathesaurus. In this case, T2DM was actually it's partially in UMLS. It says type 2 diabetes dash T2DM. Similarly, for HFREF, in the Metathesaurus, it is the full name dash HFREF. We're very confident that Azure is using UMLS for training their algorithm just as is. In comparison, the reason why we're able to do so well on primary care data is our model is directly trained on FHIR labels. We skip the intermediate step of training on a generic model, and we go straight to FHIR. Second of all, we have context-aware UMLS concept recognition. We ingested not only UMLS, we also ingest vocabularies that are available from other sources, ensuring that we are able to capture terminologies like T2DM, HFREF, HFPEF, etc., etc. And finally, we have dedicated models for each domain. It goes without saying that something specific always beats the generic one, and we've done exactly that. So we have separate what we call experts on each domain. Each domain is looking for something different, and in the end, our goal is to combine three of them to do a community of voting. We're not done from there. We're not happy with our current statistics. You're seeing here that in medication, we're 88%, 77% on conditions, and less than ideal 57% on procedure, even if we beat Azure on all counts. We have been improving our results with an in-house synthetic data generator. We don't train our AI models on production data due to regulatory or contractual obligations. Instead, we make use of a synthetic data pipeline to generate pre-annotated, realistic clinical note samples with diversity and also with primary care and acute care dialects, so we can keep track of the variety of how clinicians document various things. And you could see that with this pipeline, we're able to significantly improve on our existing model. Trained without synthetic FHIR data, 55 and 51% respectively. After running the same data on anonymized primary care notes, so these are production notes that we will never use for training. These are notes that we use for validation purposes. We were able to improve it by 0.2 to 0.3 percentage points. And this is actually something that we really are doubling down on creating using large language models. In fact, we've trained our own large language model with our own vocabularies to generate very, very diverse clinical notes. And we've come up with the golden data for training purposes. So we're trained not only on publicly available data sources like Mimic 3 and Mimic 4, we're also trained with our in-house synthetic data. Most importantly is ensuring trust, ensuring that clinicians trust the output. One of the most important pillars of executing healthcare AI is the full provenance or the full traceability to source data. We ensure that each NLP-derived concept is tightly linked with the source data. So clinical users can always go back based on our prediction to determine the legitimacy of our AI output. And here is a screen on how we recognize the screening for colorectal cancer. And we're showing exactly where in the note and when that note was created, did we recognize that? In this particular case, we were able to recognize that for this particular note, the patient is to be reminded and of their upcoming colorectal cancer screening which means they have a scheduled appointment for a colorectal scan, a FIT test, actually. And so, with this layer, the clinician will know everything they need to know why they have this now in structured format. And our pipeline is really paying off. And here's what we've done for preventative care in terms of screenings. First of all, more appointments. Now, with accessing unstructured data and turning them into structured formats, we can easily identify screenings that are overdue, and clinics can now schedule follow-up appointments for these patients. Second, it leads to higher revenue. We are able to identify missed completed screenings. So they've finished it, they just haven't documented it, and will lead to higher government reimbursements. Most importantly, though, what this does unlock is better health outcomes for the clinic's population. And that is because we now have increased coverage of patient population that has taken mandatory screening tests. We are reducing the need of manual chart review, and we're increasing the percentage of compliance rate for people who are due for certain cancer screenings and certain procedures. And just to wrap up, that's why we believe that turning free text directly to FHIR is a better way to unlock clinical information.